Mm.
Good morning, everyone. Thank you for joining us for this discussion on the realities of healthcare in the US. We're just going to let people filter into the room here and then we'll get started. Okay, you guys want to
Ready?
get started here since we're just going to do intros and then other people will get in?
Yeah. Yeah, great. Thank you, Sonia. Hi, everybody. Little reminders to get started. So folks have been here before, welcome back. You know how these things go for new folks. These webinars are sort of like anything can go in here within reason, and it's sort of meant to be a very safe place to think and feel just about anything, like we like to say, but and ask just about anything. I think the only boundary really is basic kindness to yourself and others. Otherwise, I think let it rip. So today we have Claritza Rios. You guys have met Claritza before. She's awesome. She is many, many things. Claritza and I've known each other for years. Claritza is an internal medicine doctor, an ER doc, a palliative care doc, an entrepreneur, a mom, a cookie baker, all a watercolor painter. Anyway, on and on and on. But she, besides just loving Claritza, she's particularly great for this subject because she's seen healthcare from a zillion different angles. So, hi, Claritza. Welcome back, Mama.
Hi, everyone. So happy to be here. Yeah, I'm excited to be here and chat about realities of healthcare. Thank you for having me.
Yeah, Mama. So, and on that note, like you and I were talking, I will just say, and then we'll cut over to Sonia for a second. But on this big subject today, it's not an unemotional one, and there's a lot of feelings, whether you're a patient, a family member, or a provider. So we may get a little, I don't know where we'll go today, but we'll take our own cue as a safe place to think and feel. I know we've got some feelings about this, but let me just say, I think the hope is not just to rant on healthcare or to puff it up for that matter, but really, hopefully, by the end of the hour together, we'll come out with perhaps with a little better understanding, at least, of why it is the way it is and how come it feels so gnarly sometimes, and maybe we'll all get to a better understanding of it. And including in that understanding would be a little empathy for patients and families going through it, and empathy for providers trying to work within it. So if we do our job right, we'll have a little bit of balance there, but who knows where we're going to go, because again, there are a lot of feelings here. Okay, so with that prologue, yeah. So anything else you want to add to that, Claritza, before I cut over to Sonia?
Okay. Not at all. Do it.
Okay. All right, Sones.
Thank you. And thanks everyone for being here. Just want to go over logistics of how you can ask questions after BJ and Claritza have gone through the slides. So you can raise your hand and ask your question out loud and kind of chat with BJ and Claritza. Or if you prefer to not do that, you can type it into the Q&A and I will read it aloud for you. So two ways to do that after they've gone through the slides. And the chat is also open if you want to just put any notes or thoughts in there as we go along. Thanks so much for being here, everyone.
Thank you, Sonia. So yeah, guys, Claritza and I will try to be a little disciplined and keep plenty of room for the questions and comments. And that's where so much of the fun is anyway. So, all right, but we'll start with these slides, a little bit of level setting to kind of get us in the same ballpark together. So with that, and again, beautiful imagery. Thanks to Sonia putting this together. So I don't know, Claritza, I mean, boy, one sort of presupposition in here is one of the reasons why healthcare gets so confusing is there are a lot of agendas in the mix. There are a lot of things happening, and for a lot of pretty good reasons, but sometimes it can be kind of unclear what the tip of the spear is here. What are we doing? What is the main drive for all this work? So one of the big agendas here is just the advancement of science, which is no joke. It's a big goal. It's a big mandate and an important one, and the academic structure and culture around it. So I don't know, anywhere you want to take this prompt, Claritza?
Yeah, I think that patients need to feel really comfortable in asking when care decisions are being made. Shared decision making is a really big and important part of getting your plan of care in place. And so that means that you need to be a part of that decision. And so it's really important that you feel really comfortable asking questions about the whys of why procedures, tests, things are happening. Often, treatment options, especially things like clinical trials, are offered obviously as a Hail Mary, and we certainly want to make sure, or just novel things that come up for people with chronic illness. And I think it's really important to understand that clinical trials are complex, really important work that thinks of the greater good. And that's really, really important. But it's also important as you're navigating, thinking about engaging in a clinical trial, that you ask the personal questions, that you ask the tough questions about what is this going to mean for me, and how is it the day-to-day of being in a clinical trial, the risks, the benefits, that all these things aren't just super benevolent and everything's going to be great. They're meant to be positive, but there's a lot of risk that come with them, et cetera. And so when you're making decisions, you of course want to think about your community and the greater good, but it's very fair to ask questions about how things will impact you personally and what is your gain in engaging in them as well.
Yeah, a couple thoughts on your thoughts. For one, just to mention, so clinical trials, guys, as Claritza is suggesting, oftentimes we'll find ourselves interested in a trial for our own care, to get access to latest, greatest potential thinking, but also to participate in science for the meaning we make from our own experiences. It can be very beautiful to participate in research. But one of the things that just need to be very explicit about is the purpose of clinical trials explicitly is the advancement of science. The purpose of these trials is not necessarily to serve your needs per se. Now that can sound a little harsh, maybe confusing, but so please jump in with questions about that. It's really important. They're not meant to be to go against your best interests, of course, but just so you know, when you're entering a trial, you are participating in the science versus the other way around. In a sense, the main goal is to learn about these drugs and their effects in a human being. And that can go positively or negatively, or be surprised in one direction or another. But just so you know, you may benefit in all sorts of ways from a trial, but that's really not their purpose. Anything to edit on that statement? It can sound a little harsh, but it needs to be said, I think.
Yeah, ask questions, but that is exactly the truth.
Yeah.
And I think it's important to know that truth, especially when you're entering it in a situation where this may be, and I said Hail Mary, and I don't know that that's like the kindest or nicest language, but it's realistic, right? It is often a last resort of sorts. And so you're putting a bunch of emotional and future-oriented eggs in that basket. And so 100% that honesty is really important.
Yeah. And were you going to say something else? Sorry, Mom.
No, it's just that Julianne wrote, what kind of language can I use with a doctor that doesn't sound like I'm challenging their expertise, instead desiring to be more informed? I'm a huge fan of, and I would love to know your thoughts, BJ, but and Sonia, but I love the tell me more. Tell me more. Oh, I'd love to know more about that. And what if we don't do it that way? And what if this happens? And I think it's really important to dig in and be mindful that people have limits on their time, and we'll talk about that a little bit more later on. But I think if you say, and again, this is for later, but this is the agenda, these are the things that I hope we get done during this visit. And if a treatment plan is discussed, you want to not challenge it necessarily, but challenging is actually not a bad word, is saying, let's look at all that could possibly happen. So tell me more, and then what if we don't? And what are the alternatives? Very fair questions to ask. And I love when people ask that, because that's shared decision making, right? You're getting really a ton of information, and then you can make a decision. BJ?
Yeah, so right on. I think that just to get to like tactics, like I think it's really helpful to in your language and your attitude and your affect and in your confidence, you as patient or family member, it can certainly not feel this way, but you really have a lot of power if you kind of claim it, you know. And so you can say, hey, doc, sorry, maybe we can slow this down a second. I'm sorry, I'm a little confused about X, Y, or Z, or I'm not, that's not making sense, or just taking the reins of controlling some of the pace. And if it's not registering, doctors start talking in, foreign languages with Latin terms and meta, it gets often not trying to be alienating, but it can be. And it's very typical for patients to feel a little cowed by this experience. I mean, here they are, here you are, here we are as patient, vulnerable, scared, don't know which way. I mean, there's all sorts of reasons. So we may not be hearing most of what the doctor's saying. So all that is to say, back to Claritza's note, it's like, hey, like take the reins a little bit. Sort of, here's what I'm hoping to get to today, or gosh, maybe we'll need to make another appointment because that's not really making sense, or I need to think about this. Most medical decisions don't need to be made that day, especially from the outpatient world. So take that time. Don't feel forced. So that's a note. But I also should say, before we move off of this slide, your phrase "shared decision maker," Claritza, is a really shared decision making is a really important concept. And let's maybe we can open that up for a second, because I think for folks listening, there are some assumptions that go in that statement. So for one is, it is your body, it is your life. You have legal and ethical power to say no to any treatment. You don't have legal or ethical power to demand a treatment from a physician, but you can say no to anything. And that's really an important note. So that's one point. But otherwise, oftentimes I think we feel like it's my decision to be making, it's my body, it's my life, but we often don't feel in a position, whether we're exhausted, we just don't have enough information. So one way or another, we often find ourselves deferring to the physician's best, their own best thinking. And oftentimes that's fine. They are generally trying to work on your behalf, but they have to kind of know what your behalf is, what constitutes on your behalf, not generic patient X. So that means you have to get known by your doctor. You have to, and they may not ask you a lot of questions you'd like to be asked. So you may need to kind of tell them things. And another point here is shared decision-making is a thing, because we have to say that because very often, most often, patients, the care that gets meted out is the care that the doctor thinks should happen. And that often is fine, but not necessarily. So that's the default. So you need to kind of upend that default and insert yourself.
Absolutely. And become educated in it. And I love that idea of what you mentioned. It's maybe you're too exhausted, or it's just like too much, right? You're managing too much. But if your clinician understands the values and what you want to get out of that treatment, then it'll make it easier for them. And that's where it all comes together. And it's really important as we help kind of decide what the best treatment is, to know what you want to get out of it and what's important to you. We talk about what's important in life when somebody's really has advanced illness or is at end of life. Everything you do, whether you're taking a birth control pill or a hair growth medicine, whatever, what is the goal? What are you trying to achieve? How is this burdensome? How is this helpful? That's really important. We do it every day with the minor things. When things get a little bit more complicated, it is really important that those values and what you're hoping to get out of the treatment is discussed.
Yeah. I mean, for example, just to get a little more nitty gritty, boy, we could talk about this forever. We'll get off this slide in a sec. But to Claritza, to your point, like, for example, especially in advanced illness, what may be most important to you is never going to the friggin' hospital again. So yeah, I'm interested in treatment as long as it keeps me out of the hospital, for example. That's a very different criterion than, hey, I want to try anything that might help me live longer. versus I want to try anything that's going to help me be comfortable. These are importantly different goals, and they will orient your physician towards different treatment pathways. But again,
100%.
that needs to be explicit. The doc can't magically know that that's what you want. So they're going to keep assuming until you say.
Yeah.
Very.
And it can be macro-y, like more like this is sort of, I want to be comfortable, but even the day-to-day, right? Many times a patient will say to me, it is so important for me to be pain-free that it's okay for me to be a little bit more sleepy or less engaged or sleep more. But hey, on Tuesday, people are coming over. What adjustments need to happen to my plan in order for me to be awake? And I'm willing to deal with a little bit more discomfort. So it can be micro also to the day-to-day. Anyway, sorry.
Right on. And that this is the stuff, macro and micro. These are the details that will deduce your way forward, what the treatment is right for you. That's decision making that we need to get to, and those decisions are often made by these kinds of details. So don't assume anything is everything may be relevant. So say it out loud if you're wondering or ask. Then I'll say one more thing about this particular slide, academics and science. So shy of clinical trials, which as Claritza's pointed out, is usually a last resort kind of thinking or far down the road, not always. But even in advance of clinical trials, there's research happening, especially if you find yourself in an academic institution like, University of California, where Claritza and I have both worked, or whatever, these big regional academic medical centers that usually have a medical school associated with them. So even in advance of clinical trial work, there's research happening all the time. And really, there are three driving forces, at least three, actually way more, especially when you put money in the mix. We'll talk about that. But there's clinical work, that's patient care. There's education and teaching. You know that feeling where there's a resident med student in the room, layers upon layers of learners. And then research. So these are three agendas, at least, that they're in the mix, and they're not always going to be aligned with what you find to be most important. So just be aware of that. It's happening in the background. If the doc seems a little distracted, or if you heard doc is this amazing physician about this or that, that may have an amazing reputation as a researcher, which doesn't always translate to being a great clinician. So anyway, it's complicated. Let's not drown in the details here, but just to name, there's these agendas in the mix, often unspoken, and that may be why you feel like your care may be a little lower on the list of priorities than you'd like. All the more reason to advocate. So, all right, shall we move on?
Yeah, let's do it.
All right. So here again, let's not make it, Claritza and I are physicians, and we also have a lot of antipathy towards the system in which we've worked and burned out and blah, blah, blah. And so I don't want to set this slide up as sound like in any way making excuses for what can often be rough care. But the truth is, it's very hard to be a clinician. There are a lot of things pulling on you. And most clinicians are going to want to spend a lot more time with you than they can. You can probably safely assume that, no matter what the sort of affect you're bumping into. So in here, charting has become a monster. That's EMRs, electronic medical records. That's the acronym there. That has become a monster for clinicians. It saps so much time and energy. And there's so much to say about just how unhelpful that energy is. A lot of it is meant to legally protect a provider or the institution. There's, again, agendas even in the EMRs. So just know the administrative burden is enormous. The time constraints are enormous. Depending on the kind of practice, this doc may be seeing, you may be one of 20 or 30 or 40 people they're seeing that day. So it's rough. And then all that amounts to, what increasingly is described as moral distress. We clinicians didn't go into this work to fill out charts and to cut you off in a sense because we had to go see someone else. It feels terrible on the other end too. And we know somewhere, we physicians, often clinicians, let's say nurses, social, all of it, we know that you could be getting better care than we're able to give you often enough given the constraints. And that sucks for everybody. So just want to name that. What else to say in here, Claritza? What else would you add to this?
Often the goals for a lot of checklists and boxes and data that needs to be entered is really in an effort to fix a problem. And so we took a big wide net to fix the problem, and it's clunky and messy. And then that adds to the clinician. And two, sometimes it is because there's a population health goal, right? Like we need to make sure that all these people get X treatment, or we look at this. So it comes a lot of times, some of the stuff we have to do comes from a good place. It's just the way in which it's been laid out isn't ideal. And so we see that, and it's like, you see that you get that push and pull. And so that further affects our distress, because in there's a teeny bit of, we're like, this could be helpful if done differently. But I think another thing that is really important to note is that the system is bursting at the seams, and the thing that's holding it together is the people, the social workers, the nurses, the doctors. And so people can always give an extra 2 minutes, and no making excuses for anything or anyone, but like one could imagine that if you're dependent on people, that it can have a huge impact on their wellness and their ability to fill their own cup so they can come and provide for you. And that is not something that we do well, because we went into this because we wanted to be of service to others. And so it's really difficult to not spend an extra few minutes making a phone call, etc., and then spending 8 hours at home charting when you're trying to like do laundry, take care of your partner and whatever else, and your puppy. And so it just builds on itself. And I think there's a huge shift post-pandemic into what people are willing to do because of this moral injury that has happened, and just a lack of equity in healthcare that we have seen. And I'm optimistic for solutions, but it is really difficult to watch the exodus of people leaving healthcare right now. It's kind of a bummer.
It is. It's very sad, which of course just further stresses out a very stressed system.
Right.
And of course, we as patients, it's not our fault. It's not our responsibility, but we will feel the effects of it. Right. And that's on top of a medical model that is inherently pretty reductive towards physiology, towards anatomy, towards certain aspects of physical life. Do you have a pulse? These kinds of questions.
Right.
Really important. It's great. It's important to have a pulse. But the other thing to mention here is that extrusion, that sort of pushing this incredible experience of being a human being, living through vulnerabilities and frailties and things going wrong, and looking for solutions, and life and death hanging balance. This is big stuff. And to ram all that human endeavor and experience through the medical model, all sorts of things get clipped off accidentally, and again, not malevolently. But this also conspires with our sort of drive for specialization. So, you can see someone who just focuses on one body part or one little issue, but you might feel the lack of anyone putting you back together again. We're very good at dismembering people in medicine. We're not so good at putting folks back together. And that often falls on you, the patient, to do. So again, here, just naming it so you don't feel alone in these experiences.
Right.
I'll say one more thing about this, by the way, FYI, as an aside. I mean, these realities that we're talking about here, the issues with the medical model, are very much why Sonia and I started Mettle Health, by the way, to pull it out of the medical model. So we don't have to worry so much about charting and blah, blah, blah. We can go into those details. But just to say, a lot of us who are clinicians who love medicine and healthcare are finding the need to step out of that structure to some degree to create the services that we can believe in. So that's a little bit what's happening here, subtext in the background, FYI, guys. Okay, shall we move ahead?
Yes.
Ready?
Let's do it.
Well, we've been implying a little bit about this agenda here. Part of the punchline, what's driving care? Well, I think this is where it starts getting, one of the ways it can get a little upsetting. I think the answer to that is unfortunately very clear, and that is the dollar. There's some truth to that. Medicine is big business, enormous business, roughly a fifth of our GDP. And by the way, your physician, nurse, chaplain, social worker, those guys aren't seeing these dollars for the most part. There's 8 zillion middlemen involved now in the provision of care and all the structures around it. Again, well intended, but I don't think our job here is to critique capitalism per se. And I'm not an economist; I wouldn't have a very good critique. Although I can say, as someone who's a living human being, that there are bottom lines that seem more important than the dollar, and especially when it comes to a service like healthcare and medicine, which, depending on your belief system, of course, this seems a little bit more than just your standard commodity. This seems to be a little bit more important. I think we're talking about trying to protect and preserve and celebrate life. It's much bigger than any one criterion like a dollar or financial incentives, etc. Money's important. We live in a world where it's important. Let's not be silly about it. But I think we're kind of out of whack. And too often, the tail is wagging the dog. Here, tail is leading the dollar. The money should flow if you're providing good care. If the system is well, the system is not well. It's bloated. It's confusing. It's counterintuitive. Money is going who knows where. So there's a policy piece to this. There's also a social piece for us as a country. What kind of system do we want? Is healthcare a right, or is it a privilege that you earn through good fortune? These are big questions, and we got to get serious about answering, because this system is in trouble. It's been in trouble for a while, and the needs are just growing. So anyway, there's my little soapbox. Claritza, I know you've got feelings about this too.
I have really strong feelings about it, and I'm glad that you took this slide because I feel really strongly that healthcare is a human right. And the interesting thing about this is that the data speaks to the way we're doing it isn't working, and the way other countries are doing is working better, right? And so I feel there's so many politics that come into what's driving care and capitalism, as you say. And so but the proof is in the data that we're seeing, right? And when you treat something that should be a right as a commodity, then the outcomes don't align, and we'll talk a little bit more about that. But I think the important thing for folks to take away is that it doesn't feel, as a provider, often, and I'm speaking from just personal, but also just like friends and folks that are in community with me, it doesn't always feel like you're in control of outcomes and driving the care, even though you're the so-called expert. And that also causes a ton of distress, right? And I don't necessarily mean, oh, I cannot give this person chemo because of X, Y, and Z, or I can't, prescribe this medication. It's like, I can't make sure that you get that medication if your insurance doesn't cover it, or I can't, those other things, or that I can't spend 25 minutes with you, that I have to spend 5, and that there's not enough hours. It all goes back to this feeling of not being able to control the care we want to give.
This history is complicated. I think at least some of the sort of medical anthropology and recent history that I've absorbed just may or may not be, it's probably complicated. But I think one of the ways, medicine was a certain way when I was a younger person. Doctors had a lot more say. And the relationship between the doctor and patient seemed more paramount. My little experience as a younger person, but in the 80s, I think there's so much money sloshing around. I think a lot of doctors also, this work does feel more important than just the rudiments of business in some way. And I think a lot of doctors treated it that way and let the money will work itself out. And look, I'm just going to provide my care, whatever else, I'm going to do this or that. To the point where doctors were just not necessarily managing the till super well. And in the 80s, it seemed like, oh, hey, insurance companies, HMOs get into the business and say, hey, well, let us do that. You don't have to worry about this dollars and cents stuff. You do your thing, that beautiful art and science that you're practicing. Great. We'll deal with the dollars and cents. And it seems in retrospect a real deal with something of a devil. I don't think HMOs are devils, but it seems to me that that's something we sold something off there that we are now playing out the logical conclusion of that, sort of outsourcing this piece of the puzzle. And as it goes, the bottom line starts running away with the entire conversation. And that's where we are. So when you're looking at your doctor, and you as a patient looking at a doctor, like, can't you just order this or that ridiculous thing you and I both know I would benefit from it, or whatever it is? And know that for all sorts of reasons, some I'm sure we don't understand, doctors have sort of given away that power. We do not have that power in a lot of important ways. We can prescribe it, I suppose we could write the prescription, but we know insurance isn't going to cover it, for example, or whatever else. So,
Right.
so be careful when you look at your doctor thinking that they could somehow, if they just spend another 2 minutes, if they just listen, if they just, but it ain't that easy, I'm sad to say. And also one more thing about this, there's like, I don't know, I've recently, my buddy Matt Judici, who's also a physician, taught me this word Moloch. It's a thing, like a Moloch is like this devilish thing that you kind of have to participate in, because if you don't participate, even if it drives you down farther, if you don't participate, then you're out of the game. We see this in politics. Like I have to participate. If I'm not in the game, well, then I can't do anything. In medicine,
Right.
I gotta. This is a terrible thing, but I gotta participate in it, because if I don't, then I don't see any patients. So there's this leverage, this doubling down that happens, that we are just all driving each other straight down to some lower state, a race to the bottom. And it feels really hard, like your hospital, your provider, if they step out of that rat race, then they're going to go out of business and then can provide no care. So everyone has this sort of justification. I don't like it this way, but I got to keep doing it because of, so this is points. My whole point here is this. And the individual provider, individual institution can only do so much within a model that's broken. And
Right.
until that thing is changed at the root, we're going to be in some variation on this big gnarly theme.
Yeah. And there's some positive things happening, like the role of value-based care coming into a lot of sort of the payer models. Value-based care basically incentivizes doing good stuff, especially in chronic illness. We can just order a bunch of stuff and send you to a bunch of people and do a bunch of things that may not be super helpful when you look at big picture quality and joy of life when you have a chronic illness. Value-based care really tries to look, at least in a population level, maybe not individualized care. And this is something that I'm contending with right now in my current gig. The idea there is that we get paid for doing things that make sense and that overall have a positive impact on somebody's life. And so there is some positive stuff going on there, but the government and the regulators and lawyers and people are often involved, and that makes for more EMR time and more, checklists and things of that nature. And so it's still quite imperfect. I see that a couple of people wrote a couple of things, so just a lot of plus ones on what we're saying. It's a brutal model. Our healthcare system has been built on such a bad foundation. Sadly, all of this is true. Medicine is difficult to find an altruism these days due to corporate constraints and growth. Sad to hear we're all feeling this. None of us want to work in this model. And then I left clinical practice as an alternative provider because of similar issues and the difficulty in educating people on their responsibility to be active in their patient experience, as opposed to being an employee and passively accept the recommendations dominated by other forces like big medicine, big pharma that underpin the recommendations, and the blind faith that the answers to healthcare lie in the hands of another. Yeah, and I think that's really interesting, Tamara, your point. That's why I feel it's so strongly to have really solid shared decision making. There's certain things, and I hate using analogies because healthcare, I think, is so special, right? But I will say that there are certain things in my life, even as somebody who I feel is navigated adulthood reasonably well, where I just need to be educated in finances, for example, where I invest or where I like how I deal with my taxes. I need expert knowledge there. And again, I don't want to equate human health to taxes or like a car or whatever, but there is a ton of value that you can get from having an expert who sees you and sees all of you. And I feel really strongly as an allopathic doctor that there's enough of us out there that want to do that. And I see your point, and it's really important that people need to feel empowered to ask questions, but I also feel it's our duty as providers to meet people where they are. A lot of times, because of psychosocial health equity issues, people can't show up for themselves. And so the system should exist so that we can say, if you are in a certain demographic place where you have been a victim of medical racism, where you have had really tough experiences in healthcare, you can't be that person because you don't know how to. And we as providers should be able, and physicians, nurses, social workers, patient advocates, we should show up for people and meet them there. And yeah, it's extremely frustrating. BJ, I don't know if you want to say anything about these comments. You're one.
Oh, just break.
Great, so you just muted.
What?
Yeah, we just,
back.
anyway, you're back.
Oh, hi.
You cut out. I was like, hey. No, I think there's so much. I think you and I could go off on this for hours, so maybe we'll move on. I think
Yes,
I think the point is largely made. And by the way, we don't mean to be critiquing things that we don't understand, or we understand. I guess I want to be clear here. The model is broken. I have all sorts of empathy and sympathy for people trying to make the best of that model. But until the model is changed, we're just going to be at best sort of eking out sort of salvaging something less than shitty. We're nowhere near what healthcare could be and the craft of caring could be. Okay, but we can circle back to how to maybe advocate for this kind of work too. All right, but for now, let's move on. Okay, well, here, good. I don't have to spend a lot of time on this. I mean, we've made this point one way or another, a little bit, that yes, medicine is a commodity. That's what this system the economic system we work in turns it into. That's how we thought. And thanks to Ross Perot and others, we've kind of absorbed this notion that businesses know how to run things well, and we should apply that knowledge to just about everything. The government, healthcare. And I think maybe we're at a moment now, 40 years into that kind of thinking advance, maybe it's time to revisit that. Maybe there are systems more enlightened than business per se. Business is a beautiful thing. It makes all sorts of important things happen. Capitalism makes all sorts of important things happen. Maybe it's just time for these models to evolve. And can we at least be real about what the harm that's coming and the things that are not happening through this approach. I'm not saying we should be anti-business, but is there no way to align these forces to provide better care and to make it easier for people providing it so that they can make a decent living, et cetera? I don't think we're asking too much here.
Yeah.
Anyway.
There's a universe somewhere where the business bottom line could line up with the human bottom line, right? And yeah. It's not right now. I think that that's what we're saying, but there is ways in which that could happen.
Yeah. All right. In the interest of time, I think we're going to get to a lot of juicy conversations. So I'll keep on moving here. So I know, yeah, you want to take the charge, lead here, Claritza?
Yeah, I think when this idea came up about doing this together, I immediately, of course, as a palliative care doctor, was thinking about serious illness and the realities of healthcare within serious illness. And I think one of the, and I talk about this in my lecture to non-palliative care clinicians all the time, to kind of level set and validate why sometimes it's so hard for us to navigate decline and death and dying. And I thought it would be really cool to share that reality with you all. So bear with me in my anecdote, I'll be mindful of time. So everybody goes into medicine because they want to serve. And it's either serve science, serve people, serve a community, do something bigger than themselves. And it's altruism, but altruism is really selfish, right? It makes us feel better, right? We are doing good and it makes us feel really yummy. And as we're learning and growing in medicine, we are taught and indoctrinated in certain things, like general kind of rules about what is okay, what is not okay, what makes you feel good, what doesn't make you feel good. And death and decline is one of those things. And I have this story. When I was a third year medical student, so long ago, in my surgical rotation, I was in a smaller hospital, but that did really awesome surgeries, like colon cancer surgery, really high acuity stuff. One of the colon cancer surgery experts was in this hospital. And I remember being in these like 8-hour surgeries where like your hand gets tired from having to hold something in place for a long time. So really high level stuff. This rotation, I had a super awesome, forgive my language, but badass senior surgical resident who was a superstar. I was like, I want to be like her. Assertive, kind with patients, tough, but soft in all the amazing, awesome ways. And I love working with her. I loved her patients. I was there for 6 weeks and some of our patients died. They had a very advanced illness and a lot of Hail Mary things were done to help extend their life and improve their quality of life. And many patients died. We did this conference called Morbidity and Mortality. Morbidity and mortality, we call it M&M. And now the language now is slightly different, but think of that, morbidity and mortality. And it was this really important monthly conference that happened. When that conference was happening, I was really excited because I knew we were going to talk about these cases where I saw meticulous, super scientific, thoughtful, humanistic care being provided to these patients who unfortunately died. And that morning when the presentation was happening, my super badass senior resident looked like a puppy in front of like headlights, like very, very distressed. And I didn't understand what I was. I was like, wow, you should be so excited that we're going to talk about all this work. And I quickly learned why. She got killed by all these more senior folks, including senior surgeons, about details that were missed or glossed over, that now as an attending physician, I look at and I say, I'm a little suspect about whether they really impacted the care of a dying person. Not to say that I don't want us as clinicians to be very meticulous and thoughtful about what we could be doing better, but the way in which we approach the conversation about improving our care or being more thoughtful needs to come with a big picture attached to it, not just looking at a potassium level or at a blood pressure. You want to look at the big picture. And in that conference, the fact that these folks were dying was kept out of it. And what it did for me at the time, even though I've always sort of been a palliative care doctor in my life, even then I felt like, oh, death is bad. And so that's just a little anecdote, but boy, oh boy, can you imagine that across all these little medical students, nursing students, social work interns who are coming into a system that is telling them that dying is something that they need to be worried about. And you take that a step further, you're going to do everything in your power to make sure it doesn't happen, but you're also so uncomfortable with it that talking about death, decline, dying becomes this thing that is just, I can't show up. I can't speak to it because it has been beaten into me that if I even broach that, I'm admitting my failure as a human who who spend like 20 years trying to become this, but also I'm failing you as a person. And so sorry for all the words and like made the story way longer than it should be, but I think it really gives you sort of like what's happening behind the curtain on the way we're trained. And now we need to kind of untrain ourselves of that and say the D word all the time. I'm constantly telling folks, not pass away, not death, say death. And I struggle with it too. I don't know about you, BJ, but sometimes I'll be speaking and I'll be like, death. And so, yeah, that's the little anecdote that I'll share.
Thank you, Claritza. That's helpful. It's super helpful because I don't think, so we clearly, the sort of financial imperative structure in healthcare, there's some problems there. And this other piece, I think what you're pointing us to is the culture of healthcare, the culture of medicine, and the acculturation that happens through the long training. And it's no joke. It can be very subtle. It can be not so subtle, but one way or another, I've seen so many young, beautiful hearts and minds who had all this empathy intact. You watch it get beat out of a person. And again, not malevolently. This is trying so that you can show up and do this work and do it well. These are people who have been pointing you towards this culture are brilliant, loving people often enough. So this acculturation piece is true in the world too. Cultures where things actually move, whatever culture is, it's this vague, often unspoken curriculum or agenda of sorts that has so much to say with how things move and the experience for everybody involved. And so the basic math that you're pointing us to, Claritza, is if that culture has made an enemy of the thing that you're going to do, die or decline by some measure, again, as we've said so many times here, that's going to happen to 100% of us. That's not an occasional outcome. That is a truth, a fact of nature. And here we have this system, this beautiful, advanced scientific system that somehow decided that this inevitability was its enemy. And right out of the chute, that's some cognitive dissonance at the very least. But if you can feel that play out in your training, it is no joke. It is very real. And it's why our field of hospice and palliative medicine has been such a, our work should, on the surface, should seem so uncontroversial. But in fact, when you push against these forces that we're trying to name here a little bit today, it becomes absolutely, it becomes a problem. We are a problem in this model. We are happily trying to be a sort of a gadfly in this model and gum it up. And, palliative care's job really is, yes, to take care of people, but really I think we're here as a corrective to the system. Right. We've said here before, if things move towards a palliative care kind of mindset, then this subspecialty of ours can go away.
We don't need to exist. That's right.
Exactly. This is not exotic subspecialty kind of thinking. This is what I think a lot of us would vote for should be very elemental and fundamental thinking. But it's not yet. So we're stuck with a system that we would love to redesign. But meanwhile, while we work on it, we are still stuck with the system. So here again, just want to name some forces so that you get a sense of what you're experiencing and why it is the way it is. And often maybe also in there are some tips on how to deal with it. So anyway, thank you for bringing your story into this mix, Claritza. It really helps get us out of these sort of abstract points. And by the way, you are a badass. It'd be interesting if that attending that you referenced earlier saw you now. I would love to think what she thinks of you now.
Yeah.
All grown up. And
all
knowing
grown up.
things that she didn't know. So
yeah. Thanks to her in many ways. Yeah.
Wow. And amen. Okay, so let's see here, guys. So this is the last slide. Then we can see the time here. Oh gosh.
Yeah.
Well, I mean, how to navigate? Should we just jump to questions? I think in one way or another, we've been sort of sprinkling our comments on here on how to navigate, but maybe we can synopsize a little bit. What do you think?
Yeah, I think really feel one of the things, and I see this in my own family often, it is really important for people to feel empowered to ask questions. And as providers, and I know there's a lot of providers in here. And I'm preaching to the choir here, right? But creating ways in which people can, if we need to put a pin in something, that they can kind of come back to it. That we can, in the frazzly 10 minutes that we have with them, that we can say, this can wait a week, or you can email me, or let's set up another appointment, or whatever it is, that people feel comfortable in asking for that space. And to, as like practically, I think one of the things that I have that I use with my patients as they're going back to their specialists, who are very busy, and they're amazing specialists, love specialists, they're great, and they're very busy. And because of that, how do I support? How does a patient show up to an appointment and make the most of that? Is having an agenda. And so that's a really practical thing. These are the things that I want to make sure we talk about today. And if we don't have time, how do we make sure we talk about it today? So is it a patient navigator? Is it an email? Whatever it is. And so that's kind of a really specific practical tip, but one that has been very helpful for my chronic Clio patients who are going to multiple clinicians.
Yeah, and as you're talking, I'm looking at the chat. So, I mean,
yeah.
Tamara, you give us a word here that's really important, which is agency. Control, maybe a little too unrealistic in a way, and harsh. Like, again, I think agency gets at, like, in a way, don't pretend you have no power, and don't pretend you have all power here, but rather participate in your care. See the healthcare system for what it is, a well-intended behemoth that's kind of gone off the rails, and that you can use it a little bit surgically. It can feel hard to pull out of the healthcare system. It can feel hard to say no thanks to that next treatment. It can be hard to see a world besides the healthcare system. It's so huge. But remind yourself that it is a piece of the world. It is not the whole world. It doesn't know everything. It doesn't have, you know things it does not know. Do not cede your agency, as difficult as that can be. Easiest to say and difficult to do, especially when you're traumatized and vulnerable. But one way or another, finding your way to participating in your care, reading the signals that you're getting from healthcare. I think it's really important to assume that the providers, the people that you're dealing with, mean well, but they are working in a system that is impossible. And that can give you a little bit of compassion for that provider. And it's not your job to forgive your provider for what they're going through, but just so you know how to hear them and therefore how to use them accordingly. I think that can be very, very helpful. And seek to align yourself with that person where possible, but don't wait for them. This is your life. This is your body. You can always say no, even though it doesn't feel like it. Ask questions, slow things down where you can. It's no, if we run the risk of making this sound more complicated than it really is. This is just like anything else. It's a little bit buyer beware. You got to show up. You got to participate if you have any hopes to get the kind of service and care that you really want. There's work to be done outside of just getting the care you want. Of course, for navigating the policy and politics, I think we should all start keeping an eye on candidates who are realistic about navigating healthcare and what it means to be aging and dying in this country, et cetera. So there's structural ways to get into activism. We can talk about that if you'd like, but back to the sort of basics of navigating your own care. The other thing can be very helpful is to bring someone with you, an advocate, a family member, or a friend, because it can be very hard to hear everything so quickly. So having another person with you to kind of hold space and listen with you, maybe even take notes, can be helpful. Sometimes recording a visit on your phone can be very helpful if you're out of whack and hard to know what's going on. You can listen to it later. So anyway, those are some basic tips. And I will say, just a reminder, again, this is not an infomercial, but if you're really struggling, like Lexi comments here as a nurse navigator. So find your ally in your team. Oftentimes it's a nurse. Sometimes it's a med student. Sometimes it's an admin person, but someone who actually is listening to you and you can ask questions to and say, hey, how do I get my doctor to listen to me? Or whatever. Someone you can be honest with. And it's often a nurse.
Yeah.
And then there's people here like Mental Health reach out to us and have time with us. This is what we do a lot of, is helping people, coaching people through navigating the system. So
Absolutely.
anyway, that's a kind of a quick rundown of ideas. Stones, what else is there in terms of questions or comments?
Yeah, we've got some hands up. Laureen, I hope I'm saying your name correctly, and you've had your hand up for a while. Thank you so much. You may have to unmute on your end.
Bless you and thank you. I will try to be succinct. First of all, I'm coming at this talk from a very different vantage point. I am a professional musician, an opera singer, and I am so hurt and underwhelmed by the fact that my profession is also run by the mighty dollar, and it's just really sad. But what I try to do with my music for the soul is what you're trying to do with science for the body. So getting into my personal life, 35-year career in a major opera company, feeling the squeeze of ageism, feeling pushed out, don't even work for money, work for health insurance, because my husband, a doctor, a retired doctor of dental surgery, was diagnosed with young onset dementia in 2014 at Mayo Clinic. He happens to still be alive and have a heartbeat, but he has been in hospice care since October 1st of 17. And I can't tell you how many times they have tried to push us out, move us to palliative, do this, do that. And only because of my exceptional health insurance, which half of my paycheck goes, does he get, I'll give you a quick example. They are trying to cut showers. So my bedridden, husband who poops and pees himself is supposed to get 3 showers a week. And they wanted to cut him down to 1 shower a week because we have a 24/7 live-in caregiver. And I argued and got my way, but there's other people who don't have the great health insurance I have and therefore get put by the wayside. Jumping to my most important question, and I hope this isn't too far off topic, but I desperately would like some advice. I am my husband's power of attorney. I am his everything, even though I don't do the nitty gritty of his care. He does live at home with me in the help of a 24/7 caregiver. He was diagnosed with young onset mixed dementia, non-Alzheimer's. We have gone to doctors at Rush, RADC. I have the option to donate his brain in the hope and prayer that something can be discovered to help future civilization, or even to help our children who are now worried about having dementia. The question is, I personally suspect that my husband more has something like TBI or CTE, head injuries that caused his dementia. One route would be to donate his brain to the Rush Alzheimer's Disease Clinic, although they act very kind of non-respectful, like, we have so many brains, we'll take yours, but okay. Another suggestion was to Boston University, that more concentrates on TBI and CTA. But my struggle is also, when my husband finally does decease, I don't want to just rush out his body like a slab of meat to get somewhere to take his brain. I want to honor the process and fully experience the experience. And so I know you can't tell me what to do, but if you have any recommendations on pros and cons of either of the options that I've presented, I would truly appreciate any advice. Thank you.
Thank you, Laureen. You said a lot there. And for starters, let's just say solidarity, sister. What you're doing with your family ain't easy. And thank goodness that you're doing it too. And that's a long time to be carrying in such a way. So just want to say we hear you, feel you, and you have friends here. This is your husband. So let's see about your question. I will let's see if Claritza has anything to say. I would sort of add, if my sense is, so organ donation in the classic sense means that you do generally have to be in a hospital for the organ harvesting. There needs to still be a blood perfusion, therefore a heartbeat, and organizing that can be really difficult and usually means you're in a hospital. But if I'm hearing you correctly, Laureen, the interest that you and your husband have for his body to participate in science after his death, my sense is that brain would not need to be perfused per se. My sense is the brain they would research it as and not in the sense of a viable organ that was being donated per se. So my
Correct.
sense is that you don't have to, that there's not a real time issue, that you don't have to get that brain into the researcher's hands within a certain number of minutes or hours. And that I would encourage you to clarify that by calling, when you speak to those guys, ask them if there's a timing issue of when they receive his brain. But otherwise, I think you can work with the hospice agency and say, hey guys, I'm not even going to call you when he dies. I'm going to sit with his body for a day or an hour, whatever you feel is right. And then maybe I'll make my call to you guys. I don't want to interrupt this very sacred moment of his death. If I'm hearing you correctly, Laureen, did that sort of get an answer to your question?
Yes, sir. And then like a little bit more detail is, if Rush takes his brain, they're going to be, analyzing for future generations. If I chose a different route, what I really would love is to have like a firm diagnosis. He was determined to not have Alzheimer's at Mayo Clinic because he had no beta amyloid and tau tangles, but then what does he have? My kids very desperately want to know. So whether it go to Rush or to a place that would be more searching for the TBI and the CTE route, whether there is any difference or anything.
Yes, I'd like to think that the hospice social worker could help you track down some of the answers to these questions. So if you haven't asked him or her, I would, but you may be, maybe worth a call to the coroner, because what you're talking about really is an autopsy to get after the death to get at a diagnosis. And that is a little different than work done on the brain for research purposes. So it may be that the first stop for your husband after his death is the coroner for that autopsy. And then from there, it may be possible that brain can still be used for science. But if you haven't already talked to the medical examiner or the coroner's office, I would make a call, and again, think about if you haven't already, try to enlist the help of your social worker from the hospice too to help you get some of the answers to these questions.
And I
Thank
think
you.
depending on where you live, Laureen, sorry, I cut you off.
No, I just said thank you.
Okay. I think another thing to be mindful of is like your local medical examiner, coroner there's very particular criteria within that about what they, what goes to autopsy. So learn that. And two is go back to those folks and say, what actually happens, right? So you're studying it only for like, are we looking at tau proteins only, or are we doing thorough examinations of the brains to kind of get a diagnosis, right? I think that is fair questions to ask, because with a lot of these studies, people are trying to find, a differential diagnosis, right? What else is going on? What else is presenting as Alzheimer's, like, even if it's not high levels of the appropriate protein for the diagnosis. I also think I think BJ alluded to this, way the if you have to move within 2 hours, which again, given the way in which this will be given to science, I don't think it's necessary. Is this really important to me? And it sounds like it is. What is the plan B, plan C, plan D of how I celebrate my partner's life, and how do I create intimacy and beauty and space for grief in the peri-death period. And so just anticipating, like, if I have 2 hours, what happens? If I have 2 days, what happens? And I love BJ's idea, you call them when you call them. But if it's then gonna keep you from donating, then I would just want to weigh that and just have a backup plan. But as BJ said, it was really beautiful to hear all the work that you're doing to honor your partner, and thank you so much for sharing.
Thank you. Thank you.
Thanks, Lorraine. All right, we've got another hand up, and if this is the other Bruce Miller that I'm thinking of, Bruce, you may have to unmute yourself on your end. Okay, while he's doing that, Claritza, we had another question that was written in. This person said, I am an end-of-life doula. Do you have any advice on how to speak to patients who still want hope, but also need to be educated about what kind of quality of life they may have if they're continuing treatment. It can be a difficult conversation because so many people feel they need to remain positive and hopeful.
Great question, and one that yeah, we manage every day, and BJ can speak to this as well. I think hope is different things to different people. And I always find it really helpful in figuring out people's understanding, right? So first thing when we are engaging in sort of just talking about plans or making decisions is, what is your understanding of what's coming and what's happening? And I think once you have that understanding, you're all both starting from the same place. The next thing is like, what are you hoping for? And what have you been told? And sort of see where the person is in terms of their understanding about what's happening. And once you understand what their hope is, I think there's always things to hope for, right? And so you can, as an end of life doula, be sort of like making space for the grief that kind of comes with the fact that, like, oh, I may not walk again, or I may not be able to have 0 out of 10 pain again. But what is it what can we hope for? What can we look forward to? What makes life worth living today, I think, is something that you can really support. And I think exploring people's feelings about what they've been told by their providers, especially with doulas that I speak to and help support, just creating space for that grief. When the hope they were hoping, sorry about using the word so much, but what they were hoping for doesn't always turn out to be what they were expecting. Just making space for that, and there's nothing like tell me more as a conversation continuer, if not a conversation starter, when dealing with folks that are hearing some bad news. Go ahead, BJ.
Yeah, I'm just gonna nothing to add really. Just maybe. Well, let me just say, you know, as a doula, in particular too, it's sort of in a non-clinical role. You're going to be hearing a lot of, you know, it's a particular situation. You're going to be asked questions that you don't have answers to all the time. If you were a medical person, you would be as well. But I guess where I'm going here is to say, is in your role, and maybe you're a safe place to ask questions, to say things to, and then you can say back to, well, gosh, you know, maybe next time you see your doctor, it may be hard, but you may want to ask him or her X, Y, or Z to help you get realistic here. You know, and you can be neutral third party. I don't really know myself, but I would, if I were you, I'd ask my doctor, or if I were you, you know. So there's that, is you can kind of hold the space, hold the question, and point folks back to places where they can fill in the gaps with answers from doctors to some degree. Anyway, sorry, not very articulate, but I think maybe you get the point. And the other thing is just to harken to what Claritza was just saying about hope. Hope is, you know, it's a dynamic thing. So we always would sort of hope for what? So even if you hear your client saying that they hope for something that may sound a little unrealistic, well, you could venture and say, well, gosh, yeah, man, I hear you. I'll hope for that too. And you know, have you thought about, like, gosh, what happens if that doesn't happen? Or are there other things you're hoping for? Or do you think that's what happened? You know, I don't have a sense. Does that feel realistic? You know, that's where you can sort of say, you might want to talk to your doc about prognosis or what to expect, kind of thing. But just treating hope as this dynamic, mutable thing that can shift over time in terms of what we hope for. So it's not the math here is not whether to give or take hope, whether to have or not have hope. It's more nuanced. It's hope for what.
Yeah. Hope for what? And I love that you said, and one of our friends and colleagues, Denny Shamas, is always talking about and statements. I love that you're hoping that, and I wonder if we can talk about what if it doesn't turn out that way. So it's always you like oriented to the positive, especially because you use that word specifically. I love and statements. So yay. And Danny Shamas and her end statements are the best.
Who's actually going to
Right
be on
on.
our next webinar about palliative care. A little shout out for
Yay!
that. Shayna, you've had your hand up. We unmute you here. You may have to unmute yourself. Shayna, you able to unmute? Okay. Shayna, if you have any question that you want to send us, please feel free to over email and we can do it that way. But let's see, the other Bruce, BJ.
Is that my
I
dad?
think so,
You
but I'm
there?
not-
Papa? Mom, call 911 if he's not breathing.
Wait, your dad is a Bruce also?
Yeah, BJ is Bruce Jr.
Oh, the J is Junior. Oh, interesting.
Mhm.
Hello. And I'm sorry. No, just kidding.
Well,
Just kidding.
well,
Your son is
that might be everybody. You guys got through some great stuff. Thank you so much, everyone, for being here, and thank you, Claritza and BJ. That was really just good information, as I was hoping it would be.
yeah, and it looks like there's one more comment from Lexi about coming to the event in August. By the way, guys, listeners, we're having an event in Nevada City, August 17th. Check out our website for details, mentalhealth.com. And the question was whether it would be recorded.
And it will.
Oh, you already answered it. Sorry, Sons.
No
Sorry.
problem. Happy to say it out loud too.
Okay. Anyway, yes, it will be recorded.
Thanks everyone for being here. Hope everyone
Bye,
has a good
everybody.
weekend. Bye.
Thanks, Claritza.
Thank you so much.
Bye, guys.
Take care. Thank you. Bye.
Thank you.
Bye, everyone.